everyone. Dr. Nikhil Verma here with another edition of Things That I Didn't Learn in Med School. Today, I want to talk about the landscape of where spine care is in the modern world. Quite frequently, when we get injured, a primary care physician will diagnose a patient with nonspecific low back pain, which is a terrible diagnosis because most back pain likely has one, if not multiple, pain generators. So, if these primary care physicians aren't giving us an accurate diagnosis of where this pain is, then the outcomes of that spine procedure or treatment may be misguided. This can lead to poor physical therapy, poor home exercise programs, poor chiropractic programs. But even so, even more than that, a recent study showed that less than 40% of these non-specific low back pain injuries responded to interventions or surgeries. Now, this makes sense to me if we don't have the right diagnosis and individuals go and do interventions such as injections, epidural injections, radiofrequency ablations, sacroiliac joint injections, trigger point injections, or all the way up to surgery. Of course, you're going to get the wrong outcomes because we're not diagnosing with the right primary diagnosis or the primary diagnoses. So, of course, that would make sense. But if we want to take this another step further, there are more and more devices and surgeries that are being pushed out to the public. And the most recent one that came up is the FDA just recently approved a surgery for degenerative disc disease, but the surgery is focused on fusing the facet joints. I'll talk more about this with some diagrams and some pictures in the future, but think about that. If the problem is I'm going to use my spine model here, in the disc in between vertebrae here, I know it's a clear model, but if they use this disc as the pathology and they fuse back here, sorry about that, into the facet joints, then we're not really treating the primary problem, are we? We're putting a band-aid on something else. Now, like, granted, this is kind of one of those things is, yeah, we're stabilizing the spine posteriorly because of an anterior problem, but we're not really treating the underlying problem. And unfortunately, in the US, we don't have a lot of treatments for degenerative disc disease itself, so we treat everything around it. Now, when we look at the regenerative medicine treatments, platelet-rich plasma, bone marrow aspirate concentrate, maybe some of these other devices and stem cells that are being sold and marketed. Now, you can't really market stem cells like that, and it's actually illegal. But there are some companies that are using words very intelligibly to get around those benchmarks. Some companies are in phase 3 trials to see if they pass the benchmarks, and those are the ones that are allowed to market because they are approved for research purposes. Now, these are some things that can help treat or support degenerative disc disease. But if we're using a separate device that gets approved for a diagnosis that's not the proper diagnosis, goes back to my original point. What are we actually treating? And this can cause confusion for the patients, confusions for experts that aren't in the musculoskeletal system, can cause confusion for physical therapists, chiropractors. It can cause confusion for primary care physicians. It's very confusing if the degeneration is here, why are we treating something back here if you don't know the pathology and what all this might look like? The other thing, which is very interesting, is since about 2014 or so, there's been somewhere between a 47 to 70% decrease in payments for interventional spine specialists. I will admit that back in the heyday, it was way before my time. Some of the procedures that the physicians were doing were reimbursed way too high, absolutely too high for what they were doing. Not only that, people were abusing the system. This is the heyday of when people would do 3 epidurals within a month. And then you'd come back 3 months later and do three more epidurals. Now we know that that's not best practices. That can be detrimental, and insurance has really caught on to that, and they've really, really halted those kind of treatment algorithms. But the other spine care treatments, surgeries, fusions, discectomies, laminectomies, et cetera, those reimbursements have only gone down about 14%, maybe less. It stayed a lot more steady compared to the interventional spine procedures. So this kind of guides our whole system of, if we're not getting the right diagnosis at the beginning, we're pushing patients to procedures that don't get reimbursed as well. And that forces patients into the surgery. Or sometimes this interventional aspect gets ignored completely because patients and physicians alike, primary care physicians, don't want our patients to be in pain. So they think surgery is the best option when it's not. It may not be. I have a hard time when patients come to me and say, I've had 2 knee replacements and it didn't work. I've had back surgery. I've had 8 back surgeries and my back still hurts. I sit here and try to wonder, did they have the right diagnosis from the start? Osteoarthritis, spinal stenosis. So we'll say osteoarthritis of the knee, facet joint arthritis, spinal stenosis of the spine, degenerative disc disease. Are we actually treating the right thing with the treatment options that are available? And I'd argue that we might not be. And it's very concerning for me that we look at the musculoskeletal system in the wrong way like this. I always hope that patients come to me early and they realize that we have other options when we talk about regenerative medicine therapies. Now, don't get me wrong, there are tons and tons of great therapies out there, great new surgeries, great new procedures. Even some of the older procedures and surgeries we have are still very, very good. Unfortunately, we go from point A to point Z very, very quickly with skipping all those other steps in between. And that's what's very difficult as an interventional spine physician to try to explain to patients, hey, this might not be your best option, or this is your best option. And I'll give you an example of a patient who came to me recently. He's had long-standing back pain. He's actually had a big surgery at one of the levels in his spine. And he's had another epidural since then, but this pain never went away. So he came to see me. We tried a different approach, and it gave him about 50% pain relief, not what he was looking for. And he said, and we talked. He said, I still have symptoms here, here, and here, but these symptoms went away. So we talked a little bit more. I said, we can do what insurance tells us to do, but it's just going to make things worse in the long run. Surgery is always an option at that level, but again, those other areas that might need treatment aren't getting that benefit. You're still going to have those types of pains more than likely. And also when you have surgery, it causes an inflammatory environment that can lead to a poor healing environment and a chronic inflammatory state in that region. So I really, really discussed, like, you should really consider doing a more regenerative medicine approach, giving him all his options. And after we had a thorough conversation, he agreed that this is probably the best chance of me treating the multiple levels in my spine that need different levels of care. A surgery is only going to help one level, and it's not going to help the nerve symptoms that he was experiencing. And he knew that, he understood that, and that's why he's going to likely come back here soon for a treatment of those other levels. So that is my kind of take home point today, that if we're not treating the right thing from the start, of course, our outcomes are going to be very, very poor. This is why a lot of people don't believe that PRP works, especially for the spine, because they're only treating one thing without looking at the whole musculoskeletal system, without looking at what levels might have pathology, doing a thorough physical exam, seeing the segmental differentiation of facet joints, and if there's a degree of instability on manual testing, and pairing that up with the MRI and asking the patient what their symptoms are, because sometimes what the patients had surgery for aren't the right ones. Um, and they still have pain because the surgery they had did not treat the right pathology. So that's again, the overarching point of the whole lecture today. So, anyways, I hope you guys found this useful. Please share, please like, please subscribe. If you have any questions, drop them in the comments, and I will talk to you next time. Take care. Bye.